I saw a patient in follow-up yesterday who has been on her maintenance therapy for 2 years. Her symptoms are gone. She doesn't take allergy meds, right? Her life is completely different than it was before starting treatments.
Hello, everyone. My name is Dr. Anita Lwanga. I have Dr. Karen Kaufman here with me. She's an allergist and immunologist, and I'm so excited to have you on the show. Thank you so much for agreeing to come and talk with me.
Thank you for having me. This is going to be really fun.
Yes, it will be. So I have a few questions for you, and I think the first question I'm going to ask you is to tell me a little bit about yourself and tell me a little bit about how you decided to go into allergy and immunology.
Thank you. Yes, that's a great question. So it's a little bit circuitous. My primary training is in internal medicine. And so when I did my residency, actually, I had great aspirations of becoming a cardiologist initially. And during the time of my training, there was a few different kind of clinical encounters that I had that really started to make me question if that was the right direction for me to go. And sure enough, that kind of time frame overlapped with when I had a outpatient rotation in allergy and clinical immunology, which at the time I didn't even realize was a subspecialty of internal medicine.
Mm-hmm.
I always thought about it as a pediatric subspecialty. And so I just loved it. I fell in love with everything about it. And from that point on, knew that I wanted to change the direction of where I wanted to continue training. Yeah. So it goes back all the way to my PGY2 year of residency.
Nice, nice. So you actually completed 2 years of internal medicine, is it 3 years, and then you do the subspecialty after?
Correct. Yeah. So actually, I did 3 years of internal medicine, and then after completion, I actually was a internal medicine faculty for 2 years in a family medicine training program, and then after that, I went back and did my fellowship, which is 2 additional training years in allergy and clinical immunology.
Nice, nice. So you're an internist at heart.
I have the background of an internist, but of course, what I do on a day-to-day basis is very little of what general internists do.
Mm-hmm.
So I have that background, I have that board certification,
Mm-hmm.
but I don't really practice general internal medicine any longer. But I do enjoy both adults and pediatric patients. So that's one of the fun things about my career is that you get to do both as an internist. Yeah.
Nice. What would you say is one of the most common allergies that people experience, and even your patient population? Do you feel that, say, there's certain age groups that might experience more certain types of allergies than others?
That's a good question. So yeah, I would say allergies are very common across the board. I live in Northern Virginia where pollen is a major problem for a very high population of individuals. So we do see, I would say, a bulk of our patients that we see of all ages, children, teens, young adults, middle-aged adults, even older adults who have environmental allergies to different types of allergens in our environment, like pollen or mold spores, dust, mites, dander from pets. That's very common. We do see a fair amount of patients who have food allergy, both in childhood and adults who have food allergy that persisted into adulthood. So that's also very common. We see patients who have medication allergies as well. So a lot of individuals who've had maybe a rash while on antibiotics or something like that, various drug allergies. That tends to be more so adults than children, but we see children for that too. A lot of times it's a rule out versus a rule in, which is helpful. And there's a lot of things that we can't test for. And then we also see a lot of delayed hypersensitivity, like for example, allergens that cause contact dermatitis. And we do testing for that as well. And same thing, that kind of is more maybe older kids, teens, and adults. And a lot of it is ingredients and products that we use that people develop allergy to. So it's a very wide variety of allergies, which is an allergy just in general is just a part of what we do, but it makes it really fun and enjoyable to have that kind of varied clinical experience throughout the day.
Yes, yes, yes. And I'm thinking of many patients that I come across with. People often report, say, sensitivities to certain foods, medications, or even things that they can't quite identify. So a common scenario would be somebody has an allergies to something they're not sure, they're taking an antihistamine. At what point in time would you say somebody should seek out the help of an allergist, immunologist, rather than trying to fix things on their own or trying to fix things with, say, their generalist physician that they usually seek?
Sure. I think particularly when there's persistent symptoms that are persistent enough to be taking medications on a regular basis, I certainly think for that population of individuals, it's a great idea to go see a specialist, to see an allergist, immunologist, to have allergy testing done. Because when we utilize medications like an antihistamine or maybe a nasal corticosteroid or something like that, we're utilizing meds to treat the symptoms that are associated with the problem. But really to identify what's the reason for the symptoms is extremely helpful because there are a lot of great things that we can do even from an environmental control standpoint. I always tell patients the more that we can do without even taking medicine is beneficial. So identifying what those relevant allergens are specifically is imperative to knowing what do you avoid, right? Or how do you address it? The other thing is that outside of utilizing medications for symptom control, particularly with environmental allergies, we can offer immunotherapy to patients, which really gets to the root of it and works on managing the underlying problems. Goals of something like immunotherapy would be not only to reduce symptoms, but to reduce that need for medications, but also to improve the quality of life. And you would need to have good identification of what those relevant allergens are in order to be able to consider other treatments like that. So I think that's very helpful. Certainly in the realm of food allergy, a lot of our initial diagnosis is to try to determine what is the problem. And we also see a lot of patients who have various food sensitivities or people who eat things and feel a certain way. And not all of that is mediated by the immune system making allergic antibodies, which we call IgE. Sometimes they are. So doing that diagnosis is very important to be able to help guide patients to say, look, do we need to strictly avoid if it's not really an allergy, but maybe something that, what we call food intolerance, or we get symptoms from different foods we eat for other reasons? Can we volume reduce versus strict avoidance, having an emergency plan, talking about other therapeutic modalities for individuals with primary food allergies? Yeah, I think for all of this stuff, being able to spend time with a specialist to really have an accurate diagnosis and then to really look at what are all of the options in the realm of a treatment plan become very important, because otherwise what happens is people stay on antihistamines for years and years and they don't actually feel better. They're just using meds continually to treat symptoms. I think really having a great diagnosis is very important. As much as I would love for generalists to be able to do that, and some of them can, the problem is that the time that we have with our doctors is very limited. And a lot of that is really dependent upon the insurance model here in the US. And so with that being said, particularly my background is in internal medicine, right? An internist is going to be managing lots of different, chronic health conditions, various diagnoses. They're going to be working with patients on their health screening, making sure their age-appropriate cancer screening is up to date. There's so many things that generalist needs to spend their time with their patients. I will tell you, in my experience as an internist, historically, allergy falls to the bottom of the list, right? Oh, you could just go take some Zyrtec or something like that. But even we manage, in addition to allergy, we manage a lot of other problems. And I think from a more targeted perspective, we have a lot of patients that we manage asthma. And so really having an asthma specialist, I think, is very important. And certainly we manage a lot of immune system disorders, primary immune deficiencies. And this is stuff that's sometimes outside of the wheelhouse of generalists, and as it should be, because it's just such intricate and specific things that, when I was an internist, I didn't know about a lot of those immune deficiencies either. And being able to rely on specialists to help with that kind of stuff, I think, is helpful.
Good to know. And I think you touched on a lot of very interesting things. Even going back to the previous question we were answering, you talked about immune therapy. Or immune therapy, is this a special type of medication? What does it do? How does it interact with your immune system? How does it help with allergies?
That's a great question. So in this case, specifically related to environmental allergies, when we talk about allergen immunotherapy, we are talking about specific targeted therapy that is actually created for each individual patient. So you can't just go to the shelf at the store and say, I'd like my immunotherapy, just like you could with an antihistamine, but it's going to be specific serum that we make for each individual patient. So for example, let's say you have an allergy to cats and dogs. We can make a serum that has cat allergen and dog allergen and make it customized to the individual patient's needs as far as their clinical symptom history, the size of reactivity on skin testing or on specific IgE testing, like how bad is their allergy, how significant is their response, and then targeted recommended dosing ranges. So we put that information together, we come up with a customized prescription for each patient. And literally, once we make it, the vials have the patient's name on it and the date of birth and all that stuff. So it's only used for that person. So it's very custom. Once we make these serums, we actually make dilutions of them. So when we start patients on immunotherapy, they actually are starting with a tiny dose of a very dilute concentration. These are administered subcutaneously, so people sometimes refer to this as allergy shots in this example. What happens with the immune system, even from the very beginning, is the immune system starts to shift the way it recognizes these allergens. So over time, our response to the exposure to allergens becomes much less. From an immune standpoint, we start to look at things from a different immune perspective, almost more closely to the way that our immune system looks at pathogens, as an example, versus being more hyper responsive to these allergens. People get better from their immunotherapy. And once we get through that buildup, we make it to a treatment dose. Patients will stay on that treatment dose for a period of time, which is what we call the maintenance phase. And the goal is truly to get patients off of immunotherapy at some point, but for them to stay better and to have that sustained benefit, sometimes 10, 15 years. So it's a wonderful thing to be able to offer to patients because it truly can be life-changing. And I'll tell you, allergies has a major strain, environmental allergies especially, the major strain on quality of life that patients just deal with and suffer from and feel like they're stuck with these symptoms. They have to feel that way. And it's truly not true. So they can feel better, which is really awesome.
Wow, that is very fascinating.
Yeah.
Thank you for sharing that. And that's very interesting. Everyone has probably seen those commercials for Humira. I'm trying to think of the generic names, but all these medicines that act on your immune system.
Sure.
Are any of these medicines used in allergy and immunology? And can you give some examples of maybe, say, some conditions where an individual might have medications that change the way their immune system responds?
Yeah, this is a great question. And I think a very timely question too. We refer to this group of medicines as biologic therapies. Many of them are monoclonal antibodies that are made to target specific aspects of our immune system. And they are used for various conditions that we manage as an allergist. Examples of things that we manage with biologic therapies: asthma, different types of asthma, nasal polyp, eosinophilic esophagitis, atopic dermatitis, actually chronic hives, chronic urticaria that's been something we've managed with biologics for over 10 years at this point. But now we have the latest and greatest, which is food allergy. So we actually had some great data that got published in the New England Journal of Medicine back in March of this year, where we're utilizing biologic therapy to help prevent anaphylaxis in food allergic individuals in the setting of an accidental ingestion.
Wow.
It's really awesome. These are same thing like immunotherapy. These are very targeted medicines that make a really big difference for the people who need them. It's definitely a big part of our practice, which is the management of these conditions. And sometimes these biologic therapies are part of that management plan for our patients.
Wow. So I can see allergy immunology is like a very dynamic field. I think especially now in medicine with the technology, all the advances we're having, all these new immunotherapies that are coming out, and they come out so fast you can't even keep track. Even just in a specialty like gastroenterology, I've heard that people are having to do extra specialty in inflammatory bowel diseases because there's so many medicines coming out that change the way the immune system works.
Sure.
So it's very hard to keep track of. So I can imagine for you, it's quite exciting to hear about all these new advances and conditions that couldn't have been treated a few years ago. Now we have ways to help people. That's very exciting and very fascinating. Even as we're speaking, I'm thinking about different scenarios and different patients. I think another common question that patients often come to me with is that they have chronic infections, like chronic bladder infections, chronic pneumonia. I always wonder, I'm like, there's something going on with this person's immune system, especially if they're quite young, to be seeing a doctor regularly or having all these. As we get wiser, we know our immune system gets a little bit lazy. But for, say, somebody who's like fairly like young, 20s, 30s, and they're having chronic infections, is this something that perhaps a generalist should be asking an allergy immunologist to look into for their patients? And if so, what are some of the things that you would consider?
Absolutely. That's such a great question. And we see a lot of patients who have recurrent infections. I agree. I think taking that step backwards, right? It's one thing to say, you're sick, you have this infection, take this antibiotic, get better, have a nice day, right? But when that happens over and over again, it's so important as a generalist to be able to take that step back and say, why are you so sick in the first place? That's weird. Why is this happening to you? So my threshold of who truly needs an evaluation of their immune system, there's three things. One is individuals who are sick too frequently. So too many infections, whatever that is, that should be evaluated. For example, one thing that we manage a lot are sinus infections, right? So in adults who have allergies, maybe 1 or 2 sinus infections per year might be within the realm of typical. Adults who don't have allergies, maybe 0 to 1 per year. Someone comes in with 5 or 6 sinus infections in a year, it's way too much, right? So too many infections, we should take a look at that. Infections that are too severe. So even sometimes when people aren't having a lot of infections, but they have maybe an infection and they got super sick, like maybe it was someone who had pneumonia and had a lung abscess and ended up in the ICU for 2 weeks or something like that. That's really abnormal. So we have to think about, why is that happening? And then lastly, I would say infections with unusual features, whether it's something like a lung abscess as an example, whether it's an unusual organism or something where you're just, what is going on here? So anything that makes you shrug your shoulders to say, I don't get it, I don't know why this is happening, then we need to look. So generalists can definitely get the ball rolling, sometimes with some very basic tests to take a look to see like where things are at, like even looking at globulins, which are our total antibodies, just as a generalized look. That's a nice start. Looking at a complete blood count, so we can look at how many of the white blood cells are lymphocytes and things like that. Those are some very basic things that can happen even before a subspecialist gets involved. When we evaluate patients for immune deficiency, not only are we quantifying the immune system's ability to make antibodies, but we're looking at how those antibodies specify their response, which sort of is a surrogate marker for function. And certainly depending on what type of infection or maybe what type of organism, sometimes we need to work up maybe other immune deficiencies that are even less common. Most of the time, I would say more than 50% of immune deficiencies worldwide are antibody deficiency syndromes, but there are lots of other types of immune deficiency. And to comment on your thought of how allergy and immunology is exciting because things have come a long way. When I went to medical school, I think there were 36 well-established single gene defects that were known to be primary immune deficiencies. And now certainly we've got, well over 150. And I've been practicing medicine for a while, but I'm not really that old. Things are changing. And so to be able to recognize and know these are things that we need to take a look at and do a thorough evaluation, I think becomes important. A lot of adult doctors, generalists who primarily take care of adults, don't have immune deficiency on their radar when they're thinking about patients and infections. And part of that is that many of us weren't exposed to allergists, immunologists when we were going through our training. So that's just not on the radar. Sometimes people have a false sense that these are immune deficiencies that should present in childhood, which some of them are, but some of them aren't. And we lose that sense sometimes of, hey, what's going on here? So it's really great for a generalist to be able to say, something's up with this patient. Let's get the ball rolling to start figuring it out. And then let's lean on my specialist to be able to further evaluate and make sure we're not missing something, because management becomes a different plan at that point. So super important.
Absolutely,
Yeah.
absolutely. And I found that just the proliferation of information is too much to keep track of. Even if
Totally.
like one slice of the pie, even for you as a specialist, you always have to keep up. As physicians, we always have to do continuing education because they're coming up with new diseases, new treatments. We can't keep up. And if you're more of a generalist, it's nearly impossible to keep up.
Too high.
Yeah,
Sure.
yeah, the volume is very high. And would you say, are there any allergies that you think of that can be completely cured or people can completely overcome?
Yeah, totally. When we offer immunotherapy, many people, like I said, our goals of therapy are going to be not only reduction of symptoms, but reduction in meds. For some people, that's elimination. I saw a patient in follow-up yesterday who has been on her maintenance therapy for 2 years. Her symptoms are gone. She doesn't take allergy meds, right? Her life is completely different than it was before starting treatment. So that's a great example. For some people, for example, with food allergy, some people grow out of their food allergies as they get older, and we're able to offer, an open food challenge in the office to prove that patient has outgrown their allergy. So that's another example of something completely going away. Those are, I guess, a couple of things. I would say with regard to drug allergy, a lot of times we are not really sure what happened originally, and we can't really go back in time to learn more closely. And in all honesty, sometimes an allergic reaction can look like a reaction that's not an allergic reaction. And I tell people all the time, even if I was maybe standing right next to you and you had that reaction, I really couldn't say what the mechanism is. A lot of times when people truly have drug allergy, many of the times people grow out of it, but sometimes it wasn't in the first place. We don't really know. So a lot of what we do with drug allergy is we're ruling out drug allergy now. We can't say what happened way back when, but that may be life-changing for some people too, whereas maybe certain antibiotics had been avoided because of concern for allergy, and rather than using the best, most targeted antibiotic for whatever infection they may have, maybe we're using something that's either second tier or that has another side effect profile that's unfavorable, or maybe we're using antibiotics that have a broader spectrum than we need in dealing with problems of antimicrobial resistance. So being able to say, look, we're clarifying what's going on, and maybe you don't have that drug allergy anymore. There's a lot of value to that, even if they maybe didn't have it, but proving that's the case. So that way that allows that patient to have that treatment would be very valuable.
Absolutely. Are there any situations where a patient has, say, a mysterious allergy and you're unable to find the cause? And what do you do in those situations where you've done extensive testing and people are still having symptoms?
That's a great question. And it definitely comes up more than you would know. Where the tricky part about allergy is that sometimes when we talk about having allergic reactions, we're not really talking about having allergic reactions. We're talking about reactions, whether it's due to allergy or some other factor. That's sometimes yet to be determined. But a lot of times there's presumption of this reaction must be an an allergic reaction because I have these symptoms. Whereas there's a lot of different mechanisms of how those things can come about. Depending on what's going on in the clinical history, that's truly what drives the evaluation. Somebody starts having problems of chronic hives, let's say, which are hives that are present maybe most days of the week for 6 weeks or longer. And they come in and they say, I know I'm having a food allergy to this food because I ate it 2 days before the onset of this problem, and now it's persisted for 6 weeks. Well, that's not how food allergy manifests. So sometimes just recognizing, look, let's really define the problem. Let's look at how it differentiates from what patients perceive that it might be. And then we can work up the more appropriate possible causes for their symptoms. So I think people, even with environmental allergy as a cause for rhinitis, about 25% of people have non-allergic rhinitis. People all say it's my allergies, but really what they should say is it's my rhinitis, right? Whether it's allergic or non-allergic is a totally different story. Sometimes it's really just digging into the history, really trying to figure out, well, what's happening in somebody's life? Where are these symptoms coming from? What's the story of what happened? And then really starting then to tease it out.
Yeah, you're right. I think we were told, probably med school, a lot of us, that 90% of the story or the diagnosis is in the history.
Absolutely.
And oftentimes we don't always have time to really take like a 2-page history, but if we go back and like look at the details, oftentimes the story is in there and sometimes it's not. Sometimes we as doctors cannot necessarily find a diagnosis or a treatment plan. And another thing, this is just for my own curiosity, oncology is a specialty that is very fascinating, very interesting, and I think more and more now they're using the immune system to fight certain kind of cancers. Do you see allergy immunologists playing a role in the future treatment of cancers? Or not necessarily, maybe that's completely different?
I think that really it is different. So I would say allergist immunologists much more focused on, I would say, primary immune deficiencies versus even, I guess that's really different, the answer to a different question, which is when we're talking about treating cancer, sometimes we're dealing with secondary immune deficiencies. We still help with that stuff. Let's say somebody has a B-cell lymphoma or something like that, and they end up on something like rituximab, which is a medicine that like wipes out the B cells and they're not making antibodies. Sometimes we'll still get involved with that. But when it comes to the targeted immunotherapies, I would say that probably is coming more from those who have a doctorate in pharmacology, working with clinical oncologists. I think we probably are out of the loop on that a little bit more.
Okay, that's more like research, cutting, what is it called? Benchmark kind of research, cutting edge research.
Absolutely.
Okay, very good, very good. And I think I have a few more questions for you. What would you say you love most about your work?
I think what I truly love the most is the relationships that I develop with the patients that I see. And very similar to being a generalist, we see the same patients and through their lifetime, right? So we follow them for a long time. So we get to develop those relationships, particularly because I get to see children and adults. There's a couple of families where I see 4 generations of the same family in my practice for different things. But I love the relationships that I can make with people. I love seeing them come back again and again. Let's say someone's on immunotherapy. Not only are they developing a relationship with me, but now they're developing a relationship with my entire staff because they're in the office frequently as they get their allergy shots or whatever it is. I think that I really have that joy of being with people and to truly be able to help improve the quality of their lives versus if I think I would not be in the right specialty if I was in a specialty that was maybe more transactional. I did surgery on you today and now you're better. Goodbye. Or I saw you in the emergency room and now you go to the hospital or you go home and we don't see you anymore. So I like that relationship. And I think a lot of people who are generalists in primary care like that too, because we follow the same patients over time. And there's something very wholesome about being a part of somebody's story.
Absolutely, absolutely. And especially when you see them get better with the treatments that you've worked with them to implement.
Absolutely.
That is rare, but it's very rewarding.
I would say it's less rare in my specialty. And that's one of the things that I love about allergy and immunology too, is that we truly can change the trajectory of how people live. I think when I was an internist before I became a subspecialist, as an internist doing primary care, I was managing a lot of chronic disease states, right? I really wasn't necessarily changing things for people, but I was managing things. And they were conditions that persisted despite management, whether it was hypertension or diabetes, hyperlipidemia, whatever the problems were, right? You can manage that stuff, but you can't really necessarily fix it. Sometimes you could, but not as often, right? So to your comment, it's sometimes you're just maintaining that state of health amidst a backstory of disease. Whereas with allergy and immunology, we truly are changing the way that people live. And I think that is very rewarding, especially in young people, to really be able to, for example, Like you take a child with environmental allergy, maybe they have a background of maybe some eczema when they were infants or toddlers, or even maybe food allergy, and then they go on as older kids to develop allergen-induced asthma, right? If you sometimes intervene earlier, you fix their environmental allergy with immunotherapy, they may not progress to develop that allergen-induced asthma, as their immune system now recognizes allergen differently.
Wow.
So it's really very rewarding to be able to have such a positive impact on people's lives.
That is excellent. You make me, yes, it's very cool. You make me think.
Maybe I'll do an allergy fellowship.
It's very fascinating. I actually did a rotation in allergy immunology, and my attending was is incredible man, very passionate about what he did. I think I got the interest a little bit too late for myself, but yeah, it's definitely, if I could go back in time and maybe be more organized, something that I'd really consider, especially the immune system. I found that what we studied, at least in the first 2 years of medical school, the immune system, to me, that was fascinating. And I'm sure whatever we learned is like a drop in the bucket in terms of what's really happening.
Yeah, it's the tip of the iceberg for sure.
Yeah. Maybe in another lifetime, if I could go back to medical school again, I'd choose allergy immunology, because you do have that longitudinal relationship, as you're saying, and you also actually cure things. So that's incredible.
It's pretty wonderful.
Cool.
Very blessed.
Absolutely. And I have one more question for you. It's a non-medical question.
Okay.
If you could pick a theme song to represent who you are, even just as a person or as a physician, what theme song do you think you picked?
I think I would pick the song Brave by Sarah Bareilles, which is a song about resilience and about taking risks to be able to do the right thing for people. And I feel like that resonates with me. I feel like I can identify with that. So.
Nice. So thank you so much for being a guest on my show and taking the time to answer my questions. I know I have a lot of people in my audience who have questions, who have allergies, who might be in the area that you're in, and they're looking for an allergist immunologist. So if people want to learn more about you, where can they find you in person and online?
Sure. So I have a private practice in Northern Virginia, so right outside of Washington, D.C. And the name of the practice is Kaufman Allergy, Asthma, and Immunology. And we are a growing practice. We have multiple providers who are all just the absolute best. So we serve patients in our office locally. And you can find us on our practice website, which is kaufmanallergy.com, or on Instagram, dr.kaufmanallergy.
For anyone who wants to learn more about Dr. Kaufman, if you're looking for an allergist immunologist, we will put her information below the show. Thank you guys for watching, and please send us questions. If you have any questions, please reach out to Dr. Kaufman, and we will see you on the next show. Bye-bye for now.
Thank you.